Welcome to Grand Rounds. And we have the honor and pleasure of having someone I consider a friend and colleague, Dr. Pam Popper. She's an internationally recognized expert on nutrition, medicine, and health, and the founder of the executive director of Wellness Forum Health. Her company provides educational programs, extensive libraries of videos and articles, diet and lifestyle intervention, and assistance to consumers interested in regaining and or maintaining optimal health. The company also offers professional development programs for health professionals who want to convert or start a practice focused on health instead of sick care, which is sorely needed. Though its own network of providers, Wellness Forum Health offers direct-to-consumer healthcare services. Dr. Popper has been featured in many widely distributed documentaries, including Process People and Making a Killing, and appeared in the acclaimed documentary Forks Over Knives, which played in major theaters throughout North America in 2011. She is one of the co-authors of the companion book, which was on the New York Times bestseller list for 66 weeks. She is author of The Food Over Medicine, the conversation that can save your life. Dr. Popper is featured as the lead expert in food choices, appears in Diet Fiction and Code Blue, which was released in early 2020. She is the author of the companion books for food choices and diet fiction. Her newest book, COVID Operation, which I hope she can come back and speak to us on. What happened and why it happened and what's next, which she co-authored with Shane Pryor. So this is, we're going to talk about how to become a responsible patient or a smart patient, which I really like this topic because, we've been taking calls from patients from all over the country come to our program, and I've been interfacing with them a lot more lately. And I'm hearing some horror stories. I mean, I'm getting nervous about the things I hear. I'm a little spoiled in the environment we're in. I mean, I'm practicing a standard allopathic environment, but I don't see the outrageous things that I'm hearing about. Certainly not to the extent. And let me give you a quick blurb, and I think this would be a nice way to start out. So a patient who we're treating in our center right now is a gentleman who drove himself to an emergency room in a hospital somewhere on the West Coast. I'll just put it that way. You can probably guess. Anyway, he was in an arrhythmia, a tachyarrhythmia. He went in, he had a history of heart failure and a history of atrial flutter. So he's in a sustained run of atrial flutter. Went to the emergency room. They gave him a couple of injections to get the heart rate in control. He went to the bathroom, passed out. They rushed him. They shocked him out of some arrhythmia. And apparently he came to, they put him on a ventilator. They put an intra balloon pump in him. They put him on dialysis, even though he wasn't in kidney failure. And they had him on these support. He woke up, got off the ventilator within 24 hours, was alert, but they were trying to rush him to have a heart transplant. And no workups, oh, you need a transplant emergency. And he kept refusing. Twice a day, the teams would come in and try to and fortunately, he and his wife had the fortitude to look. So he stopped all the support and he left the, they kicked him out of the hospital. And he's going to find his heart phase here in our program, recovering and all that. So I start that he's getting pressure to have a major life-changing procedure at a center that's cherry-picking patients who have a low EF who are relatively healthy otherwise to undergo that. But he was a smart patient, had the will. I think it was, not only his smarts, but I think also there's a psychological component because they scare you to death. But anyway, I'm gonna leave it there and let you take over. But I'm really excited to hear this talk because I'm hearing so many crazy stories.
Well, they are crazy. They're getting worse too. And I think the message is you want to stay out of the allopathic critical care system if you can. And the good news is that most of you can with a little bit of help. So I do have some slides. I'm going to see if this slide sharing works here. If not, we'll figure out how to do it. I'll just start by saying that I have a lot of, this is a real personal issue for me, staying out of the medical mill. And I'll tell you why. I have a picture of my mother that I would show you if I could when she was younger. And I want to tell you a little bit about my mother. And then I'm going to tell you about my father and the difference in the outcomes, and it will tell you what motivates me a lot. So my mother was a college educated woman who is spectacularly beautiful. Her wedding was in Town and Country magazine, and she was a piano teacher and just very, very smart, great conversationalist, quick wit. And she had her problems. How many people here have mothers that you had no trouble with? Anybody want to raise their hand on that one, right? But when I was a freshman in high school, my mom borrowed some money from my father. He was a successful businessman, and she opened a piano school, and it grew. She grew it to the largest chain of piano schools in the United States. At one point in time, here in Columbus, she had 2,000 piano students. That's a lot of piano students. And so, why am I telling you this? And what does this have to do with the health lecture, for crying out loud? My intelligent college graduate, concert pianist, excellent piano teacher, business person mother got sucked into the medical mill. And it started with an ill advised surgery and another ill advised surgery. And what happened after that was a descent into 15 years that I think some people can relate to. Absolute hell for my family, for my dad, from all of us. And she died when she was 78 years old. And I come from a family where people on both sides of my family live into their 90s. All right. So, terrible outcome, terrible. Now, I'm going to tell you about my dad. My father um, was smart, very successful business person. And when he was in his early 70s, I started noticing some personality changes. And he happened to be one of those people who didn't do well with statin drugs. And he was starting to get a little confused and that sort of thing. So my sister and I, we sometimes don't get along, but we agreed about one thing, and that was my dad staying well. We found out he was medicated to the hilt by this doctor. And so, long story how we got there, but my father, in his early 70s, decided to adopt a plant based diet. When he died at 93, he died in his home. This was last year. He had been kind of the life of the party until Father's Day that year. He died about 4 or 5 months later. And he weighed what he weighed when he graduated from college. Now, those are two incredibly different outcomes, right? And the big issue, really, the big difference between the two, both intelligent, successful. My dad looked just like Dick Van Dyke, spectacularly charismatic. So, what was the difference? My dad took care of himself and he lived happily ever after to a very old age. My mother chose the medical mill and she died probably at least 15 years too early after 15 years of suffering. So, which do you want to do? Which path do you want to take, right? And that's really the question that we're talking about. So, I have 10 concepts I want to talk about tonight. And the first one is that the best healthcare is healthcare, taking care of yourself. And that means you eat a great diet. It doesn't have to be perfect. And I think perfection is probably an unachievable goal, but it has to be darn near that. And of course, you've learned, you are Dr. Montgomery's patient, so you've learned that's plant-based, low-fat, high fiber, good food, good food. You have to exercise. Human beings were meant to move. You have to drink water. You need good sleep. You have to have some reason for getting up in the morning. Some of the earliest deaths, unwarranted deaths I've seen have been people who just don't have a purpose for living. You know, you got to get up in the morning and say, God put me here for a reason. You got to have stress reduction. You got to get rid of unnecessary stress. And by the way, stress-free life, good luck with that. There's no such thing. But having said that, there's a lot of stress that can be dealt with. You have to seek connection with other people. Humans are herd animals, man. We need to be around other people. And you have to build confidence in your health. Like, I think some of the people who have the worst outcomes are the ones who are worrywarts, who are sitting around all day long thinking, oh my gosh, I've got a sore elbow. I wonder if I have brain cancer. And I've got a sniffle. I wonder if I have pneumonia. Maybe I'm going to die. And I'm not telling you not to neglect your health. That's not the point. But when you have a strong, healthy body, and you know that you're strong and you're healthy. You don't take every single symptom that you have, an ache or a pain, and try to turn it into pathology and go run into doctors. Because as much as I love Dr. Montgomery, I will assure you he'd like for you to spend less time with him, except for when you go there to eat food. He'd like for you all to be visitors to the cafe, not visitors for lab results and procedures. And I mean, procedural cardiology is fantastic when you need it, interventional cardiology, but you don't want to need it. So this brings me to the next principle, number 2. You got to learn to say no to what is suggested to you by doctors who are working in the medical mill. And I think the thing we have to understand about doctors is that there are a lot of good doctors that are stuck in bad systems right now. And it's not necessarily their idea to tell you some things, but they are sort of forced to by the institutions. And I'll tell you this too, and this is a message I'm assuming a lot of those of you who are listening are patients, that people complain about their doctors sometimes, and I tell people, listen, if you want to have a better doctor, you got to become a better patient. You got to advocate for yourself. And I will say that probably 75% of the time, when we show people how to be more proactive about their health, they have a better relationship with their doctors, just because their doctors sense this person cares, doing some research, coming in for a conversation. And we've ended up with some good allies, physicians and medical institutions, who learned from their patients a lot of stuff that we're going to talk about tonight. So when it comes to what to say no to, I think that one of the things to realize is what's happened to the system. And a big shift, I think, everybody has their own idea about what happened to the system, but I'm 67 years old. And when I was a kid, we had a family doctor. Family doctor took care of my mom and my dad and my sister and I, and my aunt, uncle, 5 cousins, and my maternal grandparents. We all kind of lived in the same area. And when we visited the doctor? When we were sick. And we weren't sick all that much, right? So the idea of more medical attention and doctors helping you take care of yourself sounds really good if it's instituted really well. Because when you go to the Montgomery Center, you learn about diet, lifestyle, you eat healthy food. But when you go to another medical center, what happens is you get herded into this incessant testing. And what's happened is we're treating risk factors as if they are the disease. And I'm going to give you some examples of this. And it's motivated by big pharma. And I think we all share a little bit of disdain for big pharma these days. But one thing that happened, it was a seminal moment, in my opinion, is that drug companies started getting their representatives and associates on committees that set diagnostic parameters for disease. And so they had an incentive to keep changing those parameters so that it became harder and harder for people to be well, and easier and easier to put people on drugs, right? And I think probably the best example of that is the pre-diseases. You've all heard, there's a pre-everything. You have pre-hypertension, you have pre-diabetes, you have pre-osteoporosis, you have pre-hypothyroidism, right? And so what we really should be telling people, in my opinion, is you have risk factors for disease. Okay, so if you don't behave, you're going to end up with type 2 diabetes. If you don't behave, you're going to become full-blown hypertensive. And let me show you the side effects of these drugs, and I think I can convince you don't want to become a full-blown hypertensive patient, right? If you don't behave, you're going to end up with osteoporosis, and et cetera, et cetera, et cetera. And I think the best statement I ever heard about the pre-diseases was about pre-diabetes, which doesn't really even exist. But in the United Kingdom, the National Health Service has figured out that they've got to stop spending so much money because they don't have it. They don't print money in the UK like they print money here in the United States. So I'll just read this one line for you. The US Diabetes Prevention Program results imply that you can give an at-risk person with prediabetes a 100% chance of using metformin, with the goal of reducing by 31% their risk of developing a condition that might require them to use metformin. Now you think about that for a little minute, right? Is that nuts? And you can go through that same convoluted statement for all these other pre-diseases. So when you are told you have a pre-disease, say to yourself, that's really ridiculous. What I have is risk factors, and you know what? I can get rid of them. All right. What's your risk factor for diabetes, for example? Eating a high-fat diet, is that changeable? Yes. What is another risk factor? Being overweight, is that changeable? Absolutely. Okay. So all of this is changeable if you choose to change it, right? So when you learn to say, when I talk about learning to say no, it's learning to say no to things that don't solve the problem and have the potential to make things worse. So taking metformin for prediabetes won't prevent you from becoming a diabetic. In fact, it almost gives you permission to continue your current habits without consequence for a little while until you finally do become a full-blown type 2 diabetic. And the further down the path you get in the disease process, the more work it is to turn it around. And sometimes things happen that don't allow you to turn it around at all. So you want to say no to premature drugging. And you also want to say no to more and more and more lab tests. You know, when I started in this business 28 years ago, we used to get lab results that were 3 pages long. Now they come in a UPS box, and they're testing for all kinds of stuff. I mean, it goes on and on and on, the things they're testing for. And the more things you test for, the more things you find. And again, I'm going to use my age. At 67, I will promise you, well, first of all, let me tell you, I'm 67 years old. I don't take any drugs. I weigh what I weighed when I graduated from high school. I can bench press half my weight, and I can run 9-minute miles for 6-7 miles worth, which is pretty darn good for my age. I can teach hot yoga 2 classes in a day, and I can work 18 hours a day and I don't get tired. How do I do that? I eat great food. I have all those things I told you at the very beginning, right? But here's the thing. At my age, if we just start poking and prodding and testing and looking and imaging and everything else, you know what we're going to find? Something. But the question is, do I benefit from knowing about it at this particular juncture, right? Can you find a nodule? Can you find a streak someplace, a suspicious spot on, you start to, it's disease mongering, all right? So you want to be careful about how much medical attention you allow, and you don't want it to take the focus away from taking care of yourself. The same thing is true with screening tests for cancer. We have been told early detection saves lives for decades, right? But does it really? And a couple of examples that I'll give you is we now routinely screen people for thyroid cancer. And the number of people who die from thyroid cancer every year hasn't changed a bit. We now screen men for prostate cancer. And the percentage of men who die of prostate cancer is still 3%. So we have like 97% overdiagnosis. We screen for breast cancer. But the reality is, for every woman you help, you're going to harm perhaps between 3 and 10 women with overdiagnosis, overtreatment, etc. So when I say learn to say no as a principle, it's not that you want to say no to everything, but you really want to consider what you say no and yes to is when you're not in an emergency situation. And so this is another thing that's closely related to this. I tell people all the time, you're an adult, you don't have to justify what you're doing to anybody. But if you can't explain what and why you're doing to somebody, then you don't know what you're doing, right? So maybe you should look into it so that, somebody says to me, Pam, why aren't you getting a shingles vaccine? I can tell you why. But if I said to you, I don't know, somebody told me not to, what would you think of that decision-making process? And by the way, if you carried it over in the theater of the absurd, let's carry it over to some other aspects of life. Have you ever heard of anybody standing in the driveway with a real estate agent and saying, I'm so stupid about real estate, you're just going to have to tell me where to live? You ever heard of that happening? No. Right? So buying a house is an expensive thing. I mean, when I bought my house, this is my forever house, and it's cost a lot, and mortgage was big at one time. So I didn't stand and say I was helpless. I looked into it. What are the taxes on this place? What has to be fixed before I can move in? Can I afford to insure it, and et cetera, et cetera. So we don't claim helplessness in any other area of life, and I'm encouraging you not to do it here. And by the way, with this screening thing, I just want to share one thing with you. Many of you know that colonoscopy became a standard screening tool. And this happened decades ago. And the first randomized controlled trial on colonoscopy wasn't published until October of 2022. The first, decades after. And what it basically showed, 87,000 people in the trial, is that it does not reduce your risk of getting colorectal cancer, doesn't reduce your risk of dying of colorectal cancer, and it doesn't reduce all-cause mortality. So if you're thinking you're just going to eat, drink, and be merry and eat fat and not enough fiber and get a colonoscopy and it's going to save your life, you might want to think again. So I expect that a lot of you will be eating Brussels sprouts and brown rice when we're finished with this meeting tonight, because you'll be motivated to do that, right? So, and by the way, the much better test, less invasive, and really gets a picture of the part of the colon that's most affected, is sigmoidoscopy. We need to go back to that. We really do, because colonoscopy is a procedure that's fraught with risks. Another thing, and this goes to when I was saying I was 67 years old and I could subject myself to all kinds of tests and images and all that. You want to beware of the what we call the, and we deal with these all the time. And this is when somebody gets an X-ray for suspected pneumonia, and they find a spot on your lung. That is when you are at the biggest risk of something bad happening when you pursue it, because there were no symptoms. It's an accidental finding. That's why we call it an incidentaloma. And so it's a situation that people wrestle with often. And so whenever you start looking at imaging and testing and everything else, you also have to consider the downside. Like, what if we find something that I'd rather not know about? And by the way, if you don't think that your mental state affects your health about these things, I'll tell you something really interesting. I read a great book a couple of years ago called The Expectation Effect. And the first story in the book, it's just that the book is about exactly what I'm talking about here. You get what you expect, right? So the story that opens the book, the author, it's a true story. It's a nonfiction book. The author tells about this man who had cancer and he was cured. He was a survivor. And at a visit with his doctor, he says, I have really bad news. And that is that your cancer's come back. And I hate to tell you, but it seems really aggressive. And I don't really see you making it until the end of the year. So he dies on New Year's Day, following year. And on autopsy, they found out he didn't have any cancer. So what did he die from? Expectation. So you have to be really careful. I mean, human minds are tricky little things, right? Because it's very difficult for us to ignore some things. And so when you start letting people poke and prod around, you have to ask yourself, how will I handle this if they find something that I'd rather not know about? Here's another principle, number 4. Alternative medicine is not better in many cases and sometimes worse. Now, I have some credentials to say this. I'm a naturopath. I don't use my initials anymore because I don't like my community very much. And one of the reasons I feel that way is I feel that what happened is that the natural health modalities in our country have all become mirror images of the allopathic health system. So over here in the allopathic system, give me a symptom, I'll give you a drug. Well, let's go over here to the naturopathic modalities. Well, give me a symptom and I'll give you a supplement. And what those two have in common is that in many, many situations, it doesn't solve the problem. And so I think you have to be careful that you're not just making a sideways move into a different version of the same system. So I tell people I'm a recovering naturopath. I've been in recovery now for a couple decades. And I think I'm at the other side of it now. I have to work every day to stay on path, right? It's part of my program. It's like a 12-step program. But I learned some things that were a good idea, but I learned a lot of things not so much. And by the way, that goes to, dietary supplements. I love when people tell me how natural they are, because they're actually not so much. And I'll just give you an example. I'm gonna describe to you how they make vitamin C, because one thing you need to know is that these supplements, when they say from plant source, if humans stopped eating plants, all 8 billion of us, and we took all of the plants grown on the planet and we just put them into supplements, there wouldn't be enough to make the supplements that people buy. All right. So with that in mind, here's how we make vitamin C. You start with a starter ingredient like commercially made sorbitol, and that's a sugar alcohol that comes from fruit or corn or seaweed. So you can say from food source. See what I mean? And then fermentation with bacteria turns sorbitol into sorbose, and another fermentation step turns sorbose into 2-ketogenic acid, and 2-ketogenic acid is treated with hydrochloric acid to form crude ascorbic acid, which is filtered, purified, milled into a fine white powder to be put in pills or added to cereal. And then it's labeled from food source. So how about you eat the food source? How about that? Okay, I don't want to eat pills filled with food sourced sorbitol source vitamin C, I want to eat oranges and spinach and foods, right? So I won't belabor the supplement issue too much. And there are times I do prescribe supplements to my patients. I do sometimes. But if there is any way to avoid treating symptoms and identifying and addressing the cause, that's a much better way of doing it. And I'll tell you this too, you have to be careful of supplements because if there's an effect, there's going to be a side effect because that's the problem with drugs, isn't it? If there's an effect, there's going to be a side effect. So the question is, do we even know what it is? And is the side effect you're going to get worth the risk that you're going to take? And can you even quantify that? And when you get into all these combinations of supplements that people take, it's nobody even knows. I've had patients show up taking 20 supplements and they have no idea what they are. They can't remember why they're taking them, and they have no idea what the side effects are. And nobody on the planet today knows what the interactions of all those supplements are. So, natural is not always better. Principle number 5, become an informed consumer. And we teach people how to read the medical literature, and they often do it better than some of their healthcare providers. But it's interesting how easy it is to just start asking questions. So, for example, when cancer patients talk to us, I ask them to ask their oncologist, do you have some studies on these treatments that you're recommending for me that show survival? Because isn't that what everybody's interested in if you have cancer? How long am I going to live, right? And so when the oncologist says, well, this will extend your life by 50%, what you might be thinking in your head is, I'm 67, so I want to live to be 100. So sounds like I probably could do that. But if your life expectancy with the cancer you have is 2 years, and this extends it by 50%, that's another year, and that's 3 years. And all of a sudden, dying at age 70, I'll tell you what, it does not sound good to me at all. I don't know how you all feel about it, but I have no intention of leaving the planet willingly at the age of 70. I have too much stuff I want to do here, right? So we teach our folks how to understand the medical literature. And I'll give you a couple of examples. I think some of them are easy. Like, it's very easy to check out conflicts of interest if you're looking at health information. And by the way, even in the journals, they say that you're supposed to disclose, but they don't. But Google's a great search engine. You can just Google somebody, a researcher, and find out. For example, I was reading this one study where these doctors are talking about we shouldn't lower cholesterol. No danger, no matter how high your cholesterol is. And of course, they say no conflicts in the article itself. And then I Googled him, and one had written a book on the value of high cholesterol. He makes money selling his book. They were all invested in this high cholesterol is safe in theory. So check out the conflicts of interest, and that's an obvious one that you can look into. But here's something that is not quite so obvious. And that is, and of course, Dr. Montgomery can talk to you guys about this, and I'm sure he does, the difference between something that's statistically significant versus something that's clinically important. All right, so I'm going to give you an example. So a lot of you are familiar with Dr. Esselstyn's work. I mean, I think we're all kind of students of that, put people on low-fat, high-fiber, plant-based diets. And Dr. Esselstyn showed his first group was he had 24 patients, the 18 who stuck with it, they thrived. And I don't know if you guys remember from Forks Over Knives, but there were 4 or 5 of those patients who were told they weren't going to live for a year, and 2 of them were in Forks Over Knives with us, 30 years later, right? So that's clinically significant. All right, that changes somebody's life. When you talk to someone, I've been to his program, by the way. I've sat there with these terrified patients and their families while they introduce themselves and say, I've had 2 heart attacks, I've had 8 stents, I have bypass surgery, now they want to do it again. Okay, this is a person who's not going to live very long if they don't turn themselves around a little bit, right? And he shows them how they can live their full lifespan if they're compliant on this diet. Now, I'm going to tell you about another drug that, and I'll let you tell me what you think of this. Dr. Montgomery, you're, I'm sure, familiar with ranolazine, treats angina, right? Okay. So here's, I mean, there's a lot of data on this slide, but I'm just going to tell you the bottom line. All right. So The placebo group had 3.31 episodes per week, and the intervention group with the drug, 2.68 episodes per week, right? Does that sound like it's significant to anybody? We're going to reduce your incidence of angina by like 1/25th of a point. Like, who cares? And by the way, the side effects of this drug: dizziness, constipation, headaches, nausea, vomiting, stomach pain, dry mouth, weakness, ringing in ears, swelling in ankles and feet, tremors, slow, fast, irregular heartbeat, blood in the urine, and shortness of breath. This sounds great for a reduction of 0.25% in chest pain episodes. I mean, seriously. So that would be an example of something that's statistically significant. That's how the drug gets approved, but it's not likely to make any difference in your life. And I think that's why people get so frustrated. I've had people say to me over the years, I have great insurance. That's not necessarily an asset if you show up in a medical way. I think if I ever am really sick, I'm going to tell them I'm uninsured. Then they won't do as much to me. They'll want to get me the heck out of there as fast as they can.
That's right. They'll put you on a plant-based diet and kick you out of the hospital.
You're right. Get her out of here. No money to be made on this woman, right? So, but anyway, they're absolutely amazed that they have great insurance and they've gone to the best place and they've talked to the best doctor and everything, and things are still not going well. And the reason is because they're getting the standard of care, but the standard of care in medical centers is just actually not so great, because the basic things like looking for something that makes a big difference in your life, that's where your diet and lifestyle changes are going to really, really make a difference. So learn how to look at information. I'll tell you another one is the relative versus absolute reporting of data. So, and I kind of got into that with cancer treatment, but here's a really easy way to understand it. 1 is 1 less than 2, right? But 1 is also 50% of 2. And I'll tell you what, that 50% number is so much sexier when you talk about reducing the risk of something, doesn't it? That it's really 1. And so looking at what does this actually mean in terms that mean something to me? So anyway, principle number 7, new doesn't mean better. And there's a fascination with new. And I'll tell you a really good example. This drug, Trulicity, do you know what it costs? It costs more than the average person in the United States makes in salary in a year. And how it got approved, it's a diabetes drug. How it got approved is in the United States, the drug companies don't have to test drugs against the standard of care. So it didn't have to be tested against something like metformin. So they did a clinical trial and they pronounced that Trulicity was better than nothing. Well, I've never had a diabetic in my office where the choice was Trulicity or nothing, right? But the bottom line is that there's a number called the NNT, the number needed to treat. 337 people have to take Trulicity for 3 years to prevent 1 fatal heart attack. That was what it was supposed to be, is better for cardiovascular health, and diabetics typically have cardiovascular disease. So the cost of treatment for 337 people for 3 years is $2.7 million. And by the way, when you get into a number like 337, that means that 336 out of 337 people don't benefit. And when people sign up for something like that, I tell them, you should buy lottery tickets if you think you're that lucky. All right. Do you really think you're the 1 in 337 who's going to benefit from this drug under this scenario? So I would much rather, I don't prescribe, by the way. I have a nurse practitioner in my office who does, but when it's up to me, when I get to weigh in, I would always vote for an older drug. I would rather see a cancer patient taking Valium to sleep than antipsychotics, for example. I think that's much better. So new doesn't always mean better. Another thing is a principle number 8, understand your reference ranges. And it goes back to the drug companies having ginned up reference ranges that make everybody sick. And so one good example is that some reference ranges change with age. So we're back to my 67-year age. That's the part I can't change. But when the qualifications for a diabetic diagnosis started ratcheting down, it hit 100, and that was getting pretty marginal. Now it's 70, fasting glucose of 70 to 99. And the problem that you get into is an older patient has difficulty reaching those numbers almost no matter what they do. And so reference ranges and taking into consideration your age and also confounding factors. So I'll share a story with you. I had a patient in my office one day, and I'm looking at her food journal. She eats just like me, and she looks great, and she's normal weight. So I said, well, what brings you in today? How can I help you? She says, well, my iron levels are low. And I asked how low. She had not given me a blood test. And she told me, I said, well, that's really not very low. I said, did this just happen? She goes, oh, no, she's 47 years old, by the way. She said, no, it's been this way since high school. I said, well, what prompted you to come in here today, all these years later? She said, well, I never worried about it too much, and my family doctor didn't either, but he retired, and I went to this other doctor who seemed to think it was really important. He wanted me to take an iron supplement. I said, listen, people who are healthy people live outside the reference ranges. And then we all know somebody who weighs 300 pounds overweight and says, oh, I just got a clean report from my doctor. He says, I'm doing great. My cholesterol's good. And I'm thinking, have you looked in the mirror lately? A person who's 200 pounds overweight is not doing great. All right. So it's a form of delusional thinking we really have to sometimes address head on. But the bottom line is that your goal with health is not to look at this as some kind of test you have to pass, like you are in the reference ranges, woohoo, we're going to have a party. You really want to look at your state of health and then how much significance that being outside the reference range really has. So, and then principle number 9 is to have confidence in your immune system. The one thing I'll say about COVID is that I think it made people so nervous about their health. And in the absurd, I'll tell you, one night, it's a Friday night, and a patient who also happened to be a friend, I don't normally give my patients my cell phone number, but called me, and she goes, I'm on my way home because I just needed to talk to you. I'm sorry to bother you, but I have a sore throat, and I stopped and I got a COVID test, and it says I have COVID. So I said, she goes, what do I do? I said, well, I'm going to have to think about this for a minute because it's a real head scratcher. Okay, now this woman takes no drugs. She's 38 years old. I said, I'm reaching down into this massive amount of data I've stored in my head and all the 30 years of clinical experience and everything. And I'll tell you what's coming to my mind, first of all, is go home, make some hot tea, and rest. And then there's this silence. She goes, that's it? I said, well, I mean, you're healthy. You have a sore throat. You don't have bubonic plague, right? I mean, if you had bubonic plague, I would tell you to pull over to the side of the road. I'll come get you. We'll do some kind of intervention, but you have a sore throat. And so the reason I'm sharing this with you, a normally level-headed, young, healthy person gets all excited by the news cycle, is essentially what created this, and becomes convinced that a sore throat is the equivalent of the bubonic plague. I better call my friend, the doctor at home, and find out what to do about it because all reasonableness gets abandoned. And so I tell people that, on the one hand, you don't want to be ignoring signs. And it's amazing how somebody can look in the mirror every morning and say, it looks like I'm 100 pounds overweight. Okay, I'm just going to keep on going like nothing's wrong. But I have a sore throat. Oh my gosh, right? So not so much on the sore throat. The extra pounds, let's put our focus there, not by treating it like a 3-alarm fire, but by basically saying human bodies are meant to be lean, and yours would like to be lean too. So what do we do? Okay, well, we don't have anything exotic to talk about here. It's diet and lifestyle. I'll never forget this. One guy came in to see me. This was years and years ago, and he had nothing exotic wrong with him at all. It's just, getting older, not taking care of yourself, you're tired, you're dehydrated, and all that kind of stuff. So we talk about all this stuff, and he says, is that all you got? This is all we got, okay? You need to change your lifestyle. It's not exotic. It'll even save you money. And we have meal plans where we show people how you can eat like I do and cut your grocery bill in half, because I eat fabulous food, but it's not very expensive food, right? So anyway, and then our last principle is returning to the beginning. Where does good health come from? Good health comes from practicing good habits. over a long period of time. And I'm getting ready to teach a boot camp. It's free, by the way, if anybody wants to. It's not 9 hours, 3 hours a night, Thursday, Friday, Saturday. And I'm going to spend some time every night in the beginning talking about you have to get yourself into the right state of mind in order to achieve great health. And so I would imagine in every group I speak with, there's always somebody who says, I end up having to start over again. You know, anybody have that problem? I keep starting over again. I lose my motivation. I do well for a while and then I fall off the wagon and I don't have time and then I try to make time and but I think that instead of telling you, you got to make the time, you don't got to do anything. I think it starts this way. I think what you do is you start figuring out what are your priorities in life. All right. I'm going to tell you mine, not because I think that you should have mine. I just think you might give you some ideas. Okay. So here are mine. God is one. Community, friends, family, my circle of support, the people, the humans I hang out with, meaningful work, health, and legacy. I'm at that age where you start thinking about how am I going to leave the planet. And by the way, after God, they're not in any particular order. God's always first, but then the rest of it, they're all just equal importance because I pay attention to them. Okay, so if that's you write those down, by the way. And then your goal is every day to make your behavior align with those things. So if I say my goal is God, but I don't fast for Passover, well, somehow we have a mismatch, and that's how people get miserable, in my opinion. If I say my goal is community, but I don't ever see my friends, if I say my goal is health, but I haven't exercised since 1977, okay, so the cognitive dissonance that is created is why a lot of people are miserable. So you got to get yourself into the right state. You have to, first of all, decide what's important. Then you have to have a why. Like, why do I want to take care of myself? Why am I doing this? Why is this important to me? And what am I going to get out of it? And then what do I have to overcome? I think there are a lot of things you have to be honest with yourself. That's the beginning. You got to be brutally honest with yourself. Why do I not succeed at this? And here's my final advice. You get honest with yourself and you say it's because I don't plan. Well, then you have to start planning if you want to solve this problem. It's because I'm undisciplined and you have to solve this problem. It's because I'm afraid. I'm afraid I haven't moved. I'm afraid. What if I break something when I start exercising? Trust me, you won't if you do it safely. But write all those things down. Write down your obstacles and then figure out a plan for overcoming them. And then I think you have to keep yourself in this state every day by having some time in the morning before you start moving around to just center yourself and say, what's important to me? How am I going to make my life today reflect what's important to me? And then at the end of the day, my best advice to keep you in a good frame of mind is you start writing down things you're grateful for. And I started this with a group of friends, by the way. I'll just share this because funny story for the end, right? So in this group, somebody said, sometimes I feel like I'm writing down the same things every day. Like I love my husband or I love my wife or, and all this kind of stuff. But this one of the group members said, oh, you got to think outside the box about all the amazing things that happen, like were the clouds in the sky really beautiful today? And, the woodpecker that you got to watch on the tree outside your house. And so one day I wrote down that frozen berries at Kroger were marked down to $10.99 from $16.99. Seriously, but seriously, you start thinking about that's great, right? That was, and I remember, you think, well, that's just a little thing, and so berries were on sale, and who cares? But I remember when I saw that the berries were on sale, I thought, oh my God, I'm going to get two. It's like almost half price, and then I had a coupon, so I got one of those bags for $8.99. And you start thinking of when you really start racking your brain for stuff that you feel grateful about, it puts you in a good mood. Makes you go to bed happy, without stress. And then you get up in the morning and you start the whole cycle again. What are my values? What am I going to do today that holds me to those values? How am I going to spend my time? And it's called living deliberately, as opposed to just banding about, see what happens without any plan. And if you do that for a while, I think you're going to see a huge change in your life. So that's my story for tonight.
Wow, that is simply beautiful. You know what? It's amazing that a couple of comments I'm going to throw. I'm sure our audience has a lot of comments. I want this one thing I want to say about point number 8. But your last point is amazing. I'm going to, um, yeah, my first priority, Scott. I'm going to turn to something in the Bible that underscores exactly what you just said. it's Philippians 4:8. And I'll just be brief. Finally, brethren, whatever things are true, whatever things are noble, whatever things are just, whatever things are pure, whatever things are lovely, whatever things are of good report, if there's any virtue and if there's anything praiseworthy, meditate on these things. It's putting you. I mean, focusing on the things that are positive and grateful. It's biblical instruction and it's wise because, as you so accurately point out, our mindset is really critical. And I spend a lot of time with our patients discussing this, and there's so much I have to say about all the things you talked about. But that one I think was really point on. A little comment about the point number 8, understand reference ranges. What I try to convey to our patient and members is that there's a difference between the biological norm and the statistical norm. And oftentimes these reference ranges are taken from people who are it's from a sick population of people. And if you're outside of that range, especially on the low side in many cases, you're actually more normal than that reference range. So I think I like the way you point that out because everybody says, well, oh, I'm nervous about this number in red. And it's like, fractional point off or whatever. And it's probably better than the stuff that's not in red. But the whole point about mindset, I mean, you touched base on that, a number of your points, especially as it relates to trusting your immune system, the whole thing about coronavirus, which really underscores a lot of things that we deal with in medicine because there's a scare tactic. I alluded to that with that patient I talked about before your discussion who was trying to be, scared into getting a heart transplant. I get so many people who are bowel breathing and say, look, you need a stent, you need a bypass, you're going to die tomorrow. And the data doesn't support that. The oncologists are the absolute worst. I have a patient with multiple myeloma. He was coming to us and, he was initially started the cancer treatment. He was on, IV vitamin C and plant-based diet, and hybrid. He bought oxygen. He was doing well. And so when are you going to stop the drug? And I mean, he's out in his garden. They never stopped the drug. And so sometimes, the system wants to continue to treat for the sake of treating. Mm-hmm. And then they scare you. So look, if we don't stop this, we got to prevent this, monster of whatever it is. And so it's really, and the psychology of it is so strong. It's just amazing. And I think your point about informing yourself cannot be more important. And I think, people should probably take your class on that because it's really important to inform yourself with knowledge and going and ask the right questions, but try to be rational minded. And I think the whole idea of checking blood tests and all sorts of tests on a regular basis is also or can be problematic. Now, of course, if you're doing crazy stuff with your body, I guess you need to be checking every 5 minutes. But you have to be rational about this. You start from a foundation of what does it take to be healthy, and it's pretty simple stuff.
It's just not profitable stuff. I mean, when you take a look at the medical system, last year took in collectively in our country $4.5 trillion. And the government provided most of it. And the government can print money. You and I can't, darn it. But the government can. And so the point is that it really has turned into a money machine. And the other issue that I think people, I didn't talk about this, but I think it bears mentioning, is that the government programs disincentivize doctors from talking to you about diet and lifestyle. And one of the reasons is, for example, for a Medicare patient, and I read this in a MedPage article. This doctor was saying, I'm doing this because I want to do the right thing for my patients, but it's costing me dearly. And she gave the example of a patient with 5 diseases, one of which is type 2 diabetes. So she showed the person how to eat their way out of type 2 diabetes. So now it's one less medication, one less disease. So her reimbursement rate gets cut because he only has 4 diseases, not 5. And then she shows up as having dings on her reputation because he's not compliant on one of his meds anymore. And so the system dissuades doctors from having this conversation with you. So what's that?
It's mind blowing.
Oh, I know. And so your doctor, first of all, doesn't learn a lot about this in school. And then the second thing is the system disincentivizes it, which means the patient has to be responsible. And I think there's a part of everybody that says, well, that's ridiculous. And how come we can't fix it? Well, we can fix it over time. But the bottom line is that we're back to being the kind of consumer that you are with everything else, which is, unless it's an emergency, there's no reason to do something without checking into it first, And most of us have been burned by spur of the moment decisions to spend money or buy something before we checked it out. We learned our lessons earlier in life when I know I did when I was a lot more impetuous. I don't do that stuff anymore. So just look at taking care of your body with the same level of diligence that you look at buying a new washing machine or a car or a house or whatever. I think your body is probably the most important asset you have. And and by the way, if you were going to borrow money tomorrow and somebody said, well, we need to know what your assets are. So you say, okay, well, here's my savings account, my checking account, my house, and my retirement account, and blah, blah, blah. And of course, this body I live in, it's a pretty incredible asset because without it, I couldn't sit here and apply for a loan, right? How much is it worth? Well, I don't know, but I'll tell you this, I can't replace it. So I guess that makes it priceless, yeah? Well, why don't you treat it like it's priceless? Because it is. You get one body. You got to last your whole life. You may be able to swap out a couple parts if you're lucky. But one of my best friends works in the transplant department at OSU Medical Center. And most of the people don't get to do that. It's a very tiny percentage of people that get to swap out parts. So why don't you be nice to your liver, nice to your kidneys? Why don't you treat your heart like it's priceless? Because you only really get one. Maybe you'll get a second one, but not everybody gets that opportunity.
Yeah, and the transplant it's not a free ticket because my goodness, you're tied to these anti-rejection medications for life, and God help you if you're having side effects to them because you can't come off of them. And so right. I have more trouble dealing with post-transplant patients largely because they're sort of stuck to certain medications. And so that's certainly an issue, to be dealt with as well.
Yeah, absolutely. Absolutely.
But now this is I have a lot I want to say, but Jackie, you want to open the floor because I don't want to hog it.
Yeah, I just wanted to say that Roderick says he cannot believe that you are 67, and I've met her in person. I can't either. All right. So thank you, Roderick. Stacy said she didn't hear the test that you mentioned that you could have instead of a colonoscopy. I said it was a sigmoidoscopy, and I just want to confirm that with you. Is that correct?
Yeah. And by the way, the problem with colonoscopy has always been, and in addition to the fluids and the invasive nature of it and all that kind of stuff, is it never really gets a very good picture of the right side of the colon anyway. And so if you can't get a good picture, and by the way, the polyps on that right side are flatter, which makes them harder to, so you got a bad picture trying to detect something that's harder to detect. And so the standard of care for a long time was sigmoidoscopy, and colonoscopy became the standard of care just because the theory is more is better. More drugs, more tests, more, so, but there really never was any evidence to support it. So I'm not saying it's never usable, but I would say for the average person, if you have risk factors for colon cancer, you'd be much better off with a sigmoidoscopy, and you'd have much less risk from having one too. You don't have to go through all that stuff that you do with colonoscopy. I'm showing my age here, but when somebody in our neighborhood got childhood diseases when I was a kid, then your mother would take you to that kid's house so you would get it too. So when the kid down the street got measles, well, we all ended up there. My second grade class was out for 2 weeks, the whole class, because we all had the measles, right? Same thing with chicken pox. Some kid in the neighborhood has chicken pox, so we all go over there and play for an afternoon, and we all got chicken pox. With chicken pox, you got a lifetime immunity, and the virus does kind of hang around. But what you have to trigger it. It's usually by not taking care of yourself that causes the shingles in the first place. And so what we have now is people getting shingles when they're 70 instead of chickenpox when they're 11 or 7, right? And that's more serious than the chickenpox. And then we have people who are 40 years old getting the mumps instead of getting it over with when they're in grade school and all that kind of stuff. Would you buy a car if the car makers started complaining about the cost of compliance for certain safety issues, and the government said, you know what, these car companies are just going to start making automobiles someplace else, so we'll just not have any standards anymore, and we'll collect a tax on all the cars. So somebody brakes don't work on the car and they plow into you and kill somebody, then we'll just we'll have a fund. You can apply to the car fund to get damages for the unsafe cars that we allow people to drive. I mean, nobody would tolerate that, but that's what we have right now. So I'm cautious about all of this stuff, actually.
Yeah, it's just simply outrageous. I mean, the vaccine issue, it really shines a light on everything else that's happening that's so corrupt in medicine. And I think the thing that I'm sad about is that people are starting to wake up, but it's just, I don't know, I'm not sure if there's a psychological hold they have with the general public. There's just fear. It's hard to really put my finger on it.
Right. And those are not the people that are actually taking the drugs. The perfect patients are not the actual people. And where that's coming from, I mean, there are a couple things I think that are good to know about. One is that the drug companies are now in control of the trials. So they own the trial sites. They own the data. Most of the time, the peer reviewers are looking at the drug company's summary of the data.
Yep.
They pay prominent doctors to put their names on the articles, and the journals. I'm getting ready to sue the journals very soon. And the reason is because the journals are not in the printing the news business, they're in the reprint business. So I think the year before the pandemic started, Lancet had over $30 million in reprint business. And guess who bought it? It's all the drug companies buying reprints of articles where their drugs look great to give to their reps to sell drugs, right? And so journals are increasingly protecting the drug companies to protect their reprint business. So, and by the way, one of the reasons it's well known that the drug companies never disclose the raw data to anybody is that there have been lawsuits where the FDA has been told by the court to produce the raw data, and they've said, we don't have it. We would give it to you if we had it. So the FDA is approving drugs based on the drug company's summary of its own data, essentially. So
yeah, no, I'm aware of that, and also people are not. And, and this whole idea of guideline-directed medical therapy, doctors saying, yeah, I'm using evidence-based medicine. It's very poor evidence, and it's not the real evidence. And so, I'll have to, one of these days, we need to put together a forum with you and myself and maybe Kim Williams probably need to debate this whole issue. I think it has to be a discussion to be had on a platform where we look at, say, and we can take, say, a certain set of day, we could take the coronavirus vaccine day, whatever, and have that discussion. I think it needs to be had on a platform, recorded, and then distributed among the population so that people can say, okay, here is, the evidence, here's where it comes. Because, not only do they control the journals, but they control the governing bodies of the institutions such as American Heart Association, American College of Cardiology. And our Congress came and said, well, no, these guys are not in the room when we decide the guidelines. But of course they're in the room. They control all the studies that you use to decide the guidelines for.
Well, and that's why the NNT keeps going up. I think that the NNT for asymptomatic people taking statins for primary prevention is 400. Right. So you turn it around, 399 out of 400 aren't going to benefit. So do you think you're the one? Right. And the same thing is true for a lot of things. And I believe I'd have to go back and look at this for the accurate data, but I wrote an article about at a certain point in time as the cholesterol, John Abramson in his book Sickening wrote about it, where the Heart Association and the American Association of Cardiology, they all got together with the drug companies. And little by little, they started expanding the use of statin drugs until they actually reached a point where everybody 75 and older should take them by virtue of their age. Like you hit your 75th birthday, happy birthday, here's your prescription, go to Walgreens and get your statin drugs. And it's insane. It's just insane. So, the key is knowing when you need treatment and when you don't. And minimizing how much you need. I mean, I teach by analogy, so just think of it this way. Have you ever had somebody say, I'm going to buy a car, and what I'm looking for is one that needs to be in the shop all the time because I really love my mechanic? Think about the absurdity of that, right?
Yes.
No, you want to buy a car that doesn't require all that maintenance, and then you do things like change the oil and have the spark plugs changed in the whole 9 yards so that you're specifically not being in the mechanic shop all the time, taking the car there. So treat your body the same way because the system is highly flawed right now. And so we can't fix it, but I think eventually we can crash it through withdrawal. So many people leave that it doesn't exist anymore in its current form. But in the meantime, everybody who's lucky enough to be in this group and have regular access to good information, you don't have to let yourself go to that extreme. You don't have to let this all happen to you.
Yeah, and the other point I'd like to raise about the drugs and the studies also is that, typically look at these drugs over a certain period of time. So the randomized control trial that shows a benefit, like the statin drugs, they were looked at anywhere from 2 to 6 years in the study. Now, early on when you use a drug, you may, let's say theoretically within the first 2 to 3 years, you'll see some benefit of the effects of the drug, and maybe you have to manipulate the data to a certain extent to show that, but you'll see that. However, over a longer period of time, so someone who's on a drug for 2 years may have a different experience than that same person on a drug for 10 years or 15 years, because there's an adverse effect of the drug that builds up over time that overcomes the so-called benefits. And we don't have data on that. And so that's the other factor that people aren't looking at. And so there are just so many different factors that are not known, in addition to the fact that the earlier data is manipulated to start with.
Yep.
So, Dr. Popper, in terms of the American Heart Association, American Diabetes Association, all of these associations, which are, we believe, as the public that's supposed to be helping us get good information, they're largely funded by the pharmaceutical companies, aren't they? I mean, don't they get some of their funding from pharmaceutical, and doesn't that impact the advice that they give?
They also are funded by big food. The Heart Association has a heart checkmark program, and people pay for this. Companies pay for this, and it's called the heart checkmark, the little logo that you can put on your food. So I visit the website every once in a while to see what they're saying is okay. And boar's head, deep fried honey basted or honey flavored turkey, deep fried turkey is on the list, and bacon is on the list. That's great for heart patients, right? And then they have this thing that I laugh every time I see it. We do not endorse desserts. Well, boy, that was, you'd be better off letting these people eat some cake and take the bacon out. I mean, it's ridiculous, right? So that's a good example. The Diabetes Association for sure is getting tons of money from drug companies. Their top funders are drug companies. And if you go to the American Diabetes Association website, their dietary guidelines really give you permission to eat anything. They say, the guidelines say at the top, there's room for any kind of dietary pattern. You can be a carnivore, you can do keto, you can do Mediterranean, you can, and so it appeals to everybody. And then you don't make anybody angry. So, that nobody's ever going to give me money for what I say because I don't make them money by what I say, right? So they're clearly pandering, I call it pandering, to their sponsors.
Yeah, American Heart Association give McDonald's has an A- rating by the American Heart Association.
Now there's some good food for heart patients, I'll tell you what. Those French fries they're terrific. If you want to avoid a heart attack, you should have those frequently.
Oh my, it's crazy. I remember walking into I was rounding the hospital and a patient with congestive heart failure. And of course, I get them on, they call it the Montgomery diet. So anyway, I was running to nurse practitioner, so we walked into the room just as the guy was serving the tray. And so I lifted the cover off the tray and there's a burger there. And so I said, what's this? Why isn't my patient eating this? Because it's supposed to. And the guy, they all know me and stuff. And he was saying, look, that's what the dietitian said. And nervously typed in the number and called it. And I said, why are you giving my patient with coronary disease and heart failure a hamburger?
It's unbelievable.
And she says, it's a cardiac burger. I said, really? I said, I'll tell you what, why don't you bring the patient a pulmonary cigarette to go with the cardiac burger? And so, I mean, so I don't know. It's a new level of madness.
Well, it is, and it goes to. Sometimes people say who are new to this whole idea, is it really the food? Like they can't believe it could be that simple. It's the food. So my response to that has always been the average adult human in 1 year eats 1 ton of food, 1 ton. Ooh. So just think about what that must look like. Like if you were looking outside in the street in front of your house, how much room would a ton of food take up? It would be incredible, right? Mm-hmm. And so how could you claim that amount of material, whatever it was, wouldn't have an impact going through your body, right? So the impact is going to be good or bad, depending on the choices you make. And one other thing I'll say about that is people say, well, what about this food? What about that food? This food's good for cancer. That food's bad for, good for heart. I tell them, listen, there's no magical foods, all right? You can't eat just a whole lot of broccoli and fix this. There's a magical dietary pattern that you have to get right. And if you do it right, you might be able to have a little cake on your birthday and stuff like that, and it won't end your life. But day to day, I mean, I think today is a great day. It's Tuesday, but it's not my birthday. It's not New Year's Eve, and it's not Christmas, and it's not, there's nothing special going on, right? So, but people live as if every day is a holiday and every meal is a feast, And then you get the smart rear-ended people who will go, well, what about National Kidney Donors Week? Do I get to whoop it up then? I tell them, no, no, that's not a holiday for our purposes.
Oh my goodness. So this is amazing. Any other questions?
Any other questions? Well, so we have somebody who has had 3 transplants, 1 kidney and 2 liver transplants due to polycystic kidney disease. And she wants to know, what should she do?
Send me an email. I'll write you an article, or I'll send you an article about it. Pam Popper at MSN.com. I've written about polycystic kidney disease, and I actually was a witness in a trial on a patient who died of PCS, PKD, who shouldn't have died. So I'll be happy to send you my article.
Copy me on that if you don't mind. I'd love to see that.
Sure.
So one other question. So since I've been plant-based, my irregular heart rhythm stopped. But as you mentioned, I'm terrified to stop taking beta blockers. I have hypotension. I actually tried once and my heart went into scary tachycardia. Emergency room doctor said, take your medication, and sent me home afraid to ever stop.
Mm-hmm.
Yeah.
I think I might turn that one over to Dr. Montgomery, because it's a medication related issue and I don't know enough about your health and what you're doing. And you have to be very careful in that situation.
Yeah, the thing is that we see drug dependency, and it's just a factor of taking a medication. I obviously want to get with the doctor's going to work me on weaning, but But you chose a great example of a beta blocker. And essentially what happens is that mechanistically, you have receptors in different parts of the body. So beta receptors exist on the blood vessels and the lungs and the heart and other places. So if you look at the beta receptors on the heart, the beta 1 receptors that control heart rate, let's say normally you start off with 100 beta receptors. And then let's say you have lots of adrenaline that stimulates and stimulates these receptors. What the body would do, it has an adaptive process. If these receptors are overstimulated, it will decrease the receptor numbers. So you'll go from 100 to 50. On the other side, if you start to block these receptors, the body will adapt and say, let's say you have 100 beta receptors normally, you take a beta blocker, you block 50 of them, the body will adapt and upregulate, say, another 50. So you have 150, you have 100 available, all 50 is blocked. If you suddenly remove the 50 beta blockers, the beta blocker drug, so the 50 that are blocked are no longer blocked, you're left with 150, so your heart has an increased sensitivity to adrenaline. And so you're going to have an increase in heart rate just based by suddenly removing that. And so typically what we do is we gradually remove that. So we remove, half the dose, a quarter of the dose. And when you remove a drug, you'll get an increase in heart rate. But that increase in heart rate will then settle down because, again, the increase in heart rate is due to increased sensitivity, but the body adapts. So let's say you have 150 receptors due to the beta blockade, you reduce some, so maybe 110, 120 are available. The heart rate goes up, but then the body it reduces the beta receptor, so then that heart rate comes down. Then you reduce the drug again, heart rate goes up, then receptor population goes down, then the heart rate comes. So there's this process of gradually weaning the medication off. And if you're aware of the fact that the heart rate will go up transiently, the fact that you know that it's going up, you know why it's going up, it's not such a nervous thing, and so on and so forth. And then, of course, you see a doctor, you got to be on the drug. But it's a matter of just sort of gradually weaning it off. And we do that a lot with patients and so on. So you just got to get with your doctor who's willing to work with you and help you wean it off. Same thing with blood pressure. It'll go up a little bit for a while, but then it'll come down. Keep doing the aggressive lifestyle things. And blood pressure and heart rate fluctuate for a lot of reasons. Cleansing effects and detox effects cause heart rate and blood pressure to go up. You're passing toxin through your system. People who are alcoholics who stop drinking alcohol, we see them a lot. And in the hospital, blood pressure shoots up 220 over 120, heart rate through the roof, and we have to give them drugs to settle it down. We call it the DTs, but the body's reacting to the detox reaction of being off alcohol, heroin, other drugs, the same thing. So it's something that mechanistically it's common. You just have to recognize it for what it is, and then address and get with your doctor who's willing to work with you. That one you have done, find someone who will.
Yeah, and that's true with a lot of drugs. We find that a whole lot of people are still being over medicated for hypothyroidism, and so that's another one where you can't just stop taking the drug. You have to very carefully lower down. And some people will say, "Well, do you think I'll be able to get off of all of it?" Well, you never know that when you start, but let's face it, 20 micrograms is better than 125. And, so you just take it as far as you can and then work on building your health as hard as you can also during that same period of time. But people are kind of anxious to stop everything. It's like, okay, now I've seen the light. I can get my body in shape. I can stop all my drugs. And so it's important to be careful, not so exuberant when it comes to throwing the prescriptions out the window. So,
no, that's a great question. It's great commentary. Jack, anyone else?
Does anybody want to raise their hand and get promoted to the stage and ask a question? If so, please raise your hand. You mentioned that you think that Valium is a better choice for sleeping. Now, that maybe this is just for cancer patients than, say, an antipsychotic. Are you at all worried about people getting addicted to Valium? Perhaps people can get addicted to antipsychotics. I don't know.
Well, I was specifically using the cancer patient as an example. I don't think people should be taking anything for sleep. And I don't think that the psych drugs are, I don't dislike anybody enough to put them on psych drugs. I mean, there's, well, and I'll tell you, you talk about nightmare to discontinue. Those are some of the hardest withdrawals, and particularly the benzos, very difficult to discontinue. Some people can't, find it really difficult. But I use that as an example because you get to a place where a cancer patient is in hospice, families trying to keep the person at home, and you've got pain and all kinds of things going on, and sleep is an issue, and so the new fashion, because the new drugs are always better. That's the mentality. And so the fashion is it's fashionable now to prescribe older or newer, more expensive drugs instead of older, cheaper drugs with a better safety profile. And so a dying cancer patient who says, I'm having trouble sleeping because pain keeps me up, you're so much better off with a cheap Valium pill than an antipsychotic, causes behavior changes. I mean, these people may be in the end of life, but they want to enjoy what little time they have left with their families. And you want them to be comfortable as all get out, not make a drug company rich, which is what a lot of this stuff is all about, And the same thing is true when I use the example of Trulicity. These newer diabetes drugs are ridiculously expensive, and they are not better. And if you go, I'll tell you a little secret you guys can do on your own. There is a website for every drug. So, Merck makes a drug. There's a good example. There's a drug called Sutent, Sutent, that's used for kidney patients, right? So you can go to the drug makers. Pfizer makes it. So you can go to Pfizer.com, but you can also go to Sutent.com and then click on health professional. Anybody can do this. Tell them you are one. They have no way of knowing. Then they'll take you to all these lovely charts where they tell you the truth about the drug. I was just doing this. I teach a clinical skills class for doctors and nurses. And so we just did this last night. So we go to this, I was showing them how to do it. You Google Sutent, and then their website comes up, and you click on that, and you go to health professional. And it basically shows you this lovely graph that says that this drug prolongs life for 5 extra months. And then the side effects are, it's the worst 5 months of hell you're ever going to experience on the planet. You will pray for death. It will seem like a welcome relief, right? So no patient who ever saw that would sign up to take this drug. They wouldn't do it. So these drugs, the new drugs that are coming out, have less and less utility and more side effects. And I have to say too, just on general principle, I refuse to ever recommend a drug where people are singing about their A1C on television to get you to buy it. I'm just saying. The woman on the Jardiance commercial who's singing about her A1C, on general principle, we should never prescribe that drug. It's just too offensive, right?
Yeah, the GLP-1 agonists, the drug or that group that they're promoting some of the newer ones for weight loss. I think that's a travesty, and that's going to blow up in our face. I mean, they already had seen problems with people with GI stasis and the like, and I've done a couple of talks on it. These drugs, my goodness, it's just horrific, and they're giving it to children. Again, no adequate data on children. They want to give it to us. They're trying to get it released in Medicare, over 65, and I think 2/3 of people in Medicare is over 75, not studied in this, looked at in the studies. So it's just outrageous what they're doing, and it's just they may as well just come out and just prescribe drugs and don't do study, and they're just so blatantly, obviously corrupt.
Right.
There's no need to pretend. I mean, maybe the drug. I guess the journals wanted to make money on the reprint, so that's why they forced them to do some kind of sham studies. At least they can publish something, pretend like they're doing science. But it's just outrageous. Outrageous.
Well, the worst part about the Ozempic and all of that is they're pandering to the public. And I've had several people who were told that they should take this drug, and what they were told at the local medical center, wherever they happen to be, is we now know that this has nothing to do with behavior or willpower or anything like that. This weight problem is just, it's not your fault. and all this sort of thing. So we're at a place right now where we have something that will help you deal with it. And then you can stop the diet cycling. And I'm sure there are a lot of desperate people who like hearing that message. And they don't really, they don't realize the side effects. So this is something interesting, I'll tell you, and it'll give you a hint to what I'm working on now. I'm always working on something that's coming. But every state in the country and the federal government have a law that states that when you are diagnosed with something or a doctor makes a recommendation, you are supposed to be told what your condition is, what the recommendation is, the risks and benefits of doing the first choice that's being recommended to you, other alternatives, and the consequences of doing nothing if you would choose to do nothing. That's the definition of informed consent. So I've always operated in a consulting capacity because I can't prescribe. I've never met anybody who has had that discussion with a typical physician in a medical center. And so what I hear every day is if I'd known then what I know now, I never would have had this test, taken this drug, whatever the bad advice happened to be. And so I think that one of the ways that we can change healthcare, in addition to educating people, is we can start going after some of the egregious things that happen for lack of informed consent. Going back to that god-awful drug Sutent, it's worthless. It's worthless because extending your life by 5 months and making it the worst 5 months that human beings will ever endure in the entire time they're on the planet, nobody would sign up for it if they knew it, right? So the key is you don't tell them, right? So you tell them, we have a new drug from Pfizer. It's good for kidney cancer patients and it'll extend your life by 50%. Listen, your lifespan is expected to be less than a year. So 50% of less than a year, not so much, right? And here are the side effects. People would not sign up for this stuff. So what I guess we're telling you guys here is, since that's not required right now, even though it should be, you have to take responsibility for figuring that stuff out before you take action. And you have all the time to do it. 95% of the decisions made about healthcare are made in non-emergency situations where you certainly have the time to look into something before you commit.
This law regarding, is that formal definition, can that be Google? Is that a formal, where can I find that?
The law firms have it. It's the basis for a lot of malpractice suits. But the legal definition of informed consent, it's on the AMA's website. It's on Cleveland Clinic's website. It's on Mayo Clinic's website. The VA has it verbatim on their website. That this is the requirement. And by the way, it's a good law because really that should be the requirement. And another thing that this is near and dear to my heart. So probably a lot of you in this group at some point in time have done a closing on a house. And it's been a long time since I did, but you know what it is. You sit there for 3 hours while they read stuff to you and you sign initials. Then they read you something else and you sign and the whole 9 yards. And if they don't do that, by the way, and they don't do it often enough, then they can go to jail. Think about that. For you to borrow money to buy a house, you got to sit through 2 hours of disclosures that you understand what the taxes are, that you understand what it's going to cost to insure this house, that you understand that all this. I remember the last time I sat through, it's a mind-numbing experience, but you can't have the mortgage unless you listen to all that stuff, right? Mm-hmm. Okay. So how is it that you can be prescribed a toxic drug or a dangerous surgery by just saying we've scheduled it for Thursday? And here's your prescription. Seriously, I mean, it's the contrast is just, it's unbelievable.
You need an operation to sign right here.
Yes, sign right here, and then people do, and the reason is trust in medicine, and I trust God. All others have to show me some evidence. Maybe that's a good way to end this.